Okay, hello everybody. My name's Liam. This is the rest of my group who have decided to leave me to it. So take notes of them and please be mean to them. So our presentation is on sensorineural hearing loss. So first of all, just a quick overview of what the ear looks like, the structure of the ear. So I'm not really going to focus on any of this area. Mostly it's all going to come from around here in the cochlea and to do with these nerves here. Okay. So inside the cochlea we have this specialised organ, the organ of Corti, which is specialised in that it has a basilar membrane at the bottom of it. At the very start of the where the sound first comes in, the high frequencies are heard, are sensed via this high frequency that makes the membrane vibrate, and further away it's the lower frequencies which make that membrane vibrate. As it vibrates, this causes the depolarization of this basilar membrane again, and the hair cells in this part of the membrane then release neurotransmitters at the synapses for these auditory nerves to produce an action potential, and that then gets fed through to the brain and we hear it as sound. Okay, so sensorineural hearing loss can manifest as mainly as people not being able to understand very easily because the sounds are confused. The noises might seem too loud. You might have a ringing sound like when you go to a gig or something, and after the night it's all high pitched. And you might feel a bit off balanced. So there are quite a few causes, as you can see there. The first one, presbycusis, I don't know if I've said that right, is also known as age-related hearing loss. This occurs due to degeneration of the organ of Corti, in the organ of Corti. Normally the outer hair cells which degenerate, but it can also be due to the spiral ganglion. And if you have degeneration in those outer hair cells, then there is lack of amplification, so the sounds aren't heard as well. Meniere's disease, which is an excess build-up of endolymph in the endolymphatic compartment of the inner ear. Now this can be permanent if left untreated. It usually starts in one ear and the hearing loss fluctuates, but eventually it spreads over to the other ear as well, or usually does anyway. Labyrinthitis is inflammation of the labyrinth in the cochlea, and sometimes infection of the vestibular nerve. It's usually a viral infection which causes this, as you can imagine, with the association in the middle ear with the upper respiratory tract, but it can be due to bacteria as well, and it can be a result of meningitis. Another thing which isn't on this slide is genetic cause. If you get aplasia of the cochlea, so as we learnt from MOD that it doesn't actually form as we grow, whatever, you can get an acoustic neuroma. I think acoustic spelt wrong there, unless it's supposed to be like that, but I don't think so. In which there's a benign tumour which grows in the inner ear and compresses those nerves just to the medial side of the cochlea. You can get a sudden onset of sensorineural hearing loss, which can be numerous causes, but it's either idiopathic, it can be due to ischemia of the inner ear, it can be due to a perilymph fistula, or it can be because of an autoimmune condition. There can be damage due to ototoxic drugs, particularly aminoglycosides, and the ones we said before about loud noise and obviously trauma. Okay, so investigation, obviously as we've been doing with the cranial nerves, when we test hearing we use the Winnies and, no, I said that wrong, Rinnies and Webbers and Rinnies, whatever it is. So you start with the Webbers on the forehead, and as we know the conductive goes to the ear that is affected, whereas if it's the other way around, if it's sensorineural, then it goes to the ear that isn't affected. But this can be definitively diagnosed with audiometry, which involves starting with a really low volume and coming up decibel by decibel until the patient can hear it, and then changing frequencies and pitch and stuff to figure out where their hearing problems lie. And we've discussed hearing loss before, but so I'll move on. So this is the results of the Webers and Rinneys, depending on whether you have sensorineural or conductive hearing loss. So as I said before, the sound localizes to the normal ear with the Weber's test for sensorineural, and it has a positive test. And positive, unlike most things we think of in medicine, means bad. Positive means normal in this case, and it's different in conductive hearing loss. So management obviously depends on how much this has affected the patient, but usually for mild and moderate hearing loss you'd use hearing aids, or more kind of drastic approach to have these cochlear implants, which are placed just behind, just post-auricular area here, and they convert the sound waves that we normally hear into electrical impulses from the outside of the skull and take it towards the nerve. And there's also a possibility of hair cell regeneration. And that's all. Any questions?